So today we'll be talking about nephrolithiasis, which is also commonly known as kidney stones. So when you come talk about types of stones, the most common which are found in majority of the population are calcium oxalate stones, followed by calcium phosphate, followed by uric acid stones and struvite stones, cystine stones, and stones composed of medications. Major or most common medication stones are acyclovir stones. So if if they ask you which is the most common, that is the calcium oxalate stones. So this is a pictographic representation of the stones. So um, coming to the calcium oxalate stones, usually it is a single stone. Uric acid stones are smaller stones which are round in shape. Struvite stone, it is triple phosphate stone. It takes the shape, as you can see here, it takes the shape of the renal calyx, okay, and cystine stones. So coming to the pathogenesis of renal stones, the first one is supersaturation. Now what is supersaturation? Supersaturation means that the substance which is excreted in urine, okay, exceeds the normal quantities and which leads to stone formation. Then presence of inhibitors of crystallization prevent stone formation. The important inhibitor of calcium stones is urinary citrate. Now, urinary citrate will inhibit the calcium stone formation, right? Now, if the urinary citrate is low because of any other reason, which will lead to formation of calcium stones. So, a very important MCQ, what is a Randalls plaque? So, usually the calcium phosphate gets deposited in the thin loop of Henle, right, which extend down the renal papilla and then erodes through the papillary epithelium. Now, this calcium oxalate stones grow on the calcium phosphate. So, calcium phosphate uh, surrounded by calcium oxalate stones together is known as Randalls plaque. So very important risk factors for nephrolithiasis. First is dietary. So the diet, if the patient is consuming diet which is high in animal protein, sucrose or fructose, it increases the risk of formation of stones. Vitamin C supplementation is associated with calcium oxalate stones. Vitamin C supplementation, which was seen in high amounts during the COVID pandemic. So if a person has taken vitamin C for a prolonged period of time at a very high dose, usually for routine prophylaxis, you prescribe vitamin C as 500 mg OD, right? But during COVID pandemic, people have taken TID doses that too for long for months and months and together. So vitamin C supplementation, they are at an increased risk of getting calcium oxalate stones. Now, certain dietary factors which are protective for the formation of stones. That is diet which is high in calcium, potassium and phytate. Now, diet which is high in calcium, potassium and phytate are protective for formation of stones. Now, urinary output which is less than 1 liter per day are associated with increased risk of stones. Sugar and sweetened beverages increases the risk. So a person who is consuming a lot of cola or aerated beverages or sweetened beverages, they have increased risk of formation of stones. Weight gain increases the risk of stone formation and incidence is highest among middle-aged men when compared to women. Now coming to certain urinary risk factors. So higher urinary calcium excretion increases the risk of calcium stones. Now if the urinary calcium is more, then there is an increased risk of formation of calcium stones. Higher urinary oxalate excretion increases the risk of calcium oxalate stone formation. So now if calcium oxalate uh, oxalate is increased, excretion is increased in urine, the calcium whatever is there in urine will bind to this oxalate and it will ultimately form calcium oxalate stones. Low urinary citrate is a risk factor. As I have told you previously, citrate is an inhibitor of crystallization. So low urinary citrate will increase the risk of formation of calcium stones. Now, urinary citrate reabsorption occurs due to high intracellular pH of the PCT and hence reduce the urinary citrate and predispose to stone formation. uh, Urinary citrate reabsorption occurs in PCT, which has due to high intracellular pH. Now, if more citrate will be reabsorbed, less citrate will be present in the urine, right? Which will lead to reduce the urinary citrate and ultimately will predispose to stone formation. Excess purine consumption and increased excretion of uric acid is a risk factor for uric acid stones. Purine consumption, increased excretion of uric acid. So uh, um, any pathology basically which increases the uric acid levels in the blood, for example gout, they have an increased chances or increased incidence of getting uric acid stones. So, uric acid stones will form when urinary pH is less than 5.5. That is when urinary pH is acidic. And calcium phosphate stones will form when urinary pH is more than 6.5, which means that when the urine is alkaline. So, calcium phosphate will precipitate in case of alkaline urine, whereas uric acid stones will be formed when the pH of the urine will be more acidic. So, alkalization of urine, in other words, alkalization of urine or any pathology which increases the pH of the urine will lead to precipitation of calcium phosphate stones. One of the important organism which goes in increased pH is, it's a very important MCQ, is Proteus organism, Proteus mirabilis. So Proteus grows in case of alkaline pH and it is very important risk factor for formation of triple phosphate stones, especially also known as struvite stones. Now coming to approach to a patient with kidney stones. Now patients with kidney stones remain asymptomatic until many years, until symptoms develop. Now, what are the symptoms for the patients with kidney stones? What are the clinical features? They present with colicky pain, which is also known as renal colic. Renal colic, the most common region is the lumbar region, right? And the pain will radiate to the groin. Patient will present with painless gross hematuria. The stone will irritate or will erode the inner epithelium of the renal pelvis or ureter or renal calyx and ultimately will cause gross hematuria which will be painless. There will be flank pain. The patient will present as nausea, vomiting and the pain will radiate to the groin. So all these are the symptoms of renal nephrolithiasis, that is renal stone, that is renal colic, painless gross hematuria, then flank pain, nausea, vomiting and pain that will radiate to the groin. Now coming to differential diagnosis, in case of flank pain, in case of lumbar pain, what is the differential diagnosis you would keep in mind in case of renal stone? One is acute cholecystitis. But in case of acute cholecystitis, the pain is more in the upper right hypochondriac region. The pain will radiate towards the right shoulder and the back, right? And the patient will present as nausea, vomiting. Patient will present as abdominal pain. So a right renal stone or acute cholecystitis may present as nephrolithiasis. In cystitis, pelvic inflammatory disease (PID), and appendicitis, obviously right uh, lower quadrant pain associated with nausea and vomiting. Always think of appendicitis, but renal colic can also be one of the causes. Diverticulitis. Diverticulitis mostly will present as left hypochondriac, left iliac pain, when patient will present as fever, abdominal pain and vomiting. Abdominal aortic aneurysm. In case of abdominal aortic aneurysm, patient will present as abdominal pain, and it will present as central pulsatile mass in abdomen. So, a urinary tract infection in a setting of an obstructive stone, a completely obstructive stone, is a medical emergency, because if you don't relieve the obstruction, the infection will spread through the upper part of the kidney, and the stone will also act as an nidus of infection, and ultimately will end up in damaging the entire kidney. So, a UTI in a setting of obstructive stone is a medical emergency. Immediate drainage by ureteric stent or percutaneous nephrostomy is indicated. By placing the stent and removal of the stone, and percutaneous nephrostomy. Percutaneous means through the skin, through the skin. Nephrostomy means making an opening. Nephro means kidney. So via the skin, you will make an opening in the kidney, and you will drain the pus and remove the stone. Now coming to how will you diagnose a case of nephrolithiasis. So helical CT is the modality of choice. On CT scan, usually you can see the majority of the stones, which can be missed on USG. Urinary analysis may show hematuria. Crystals in urine examination. You will see different types of crystals in urine. Calcium phosphate, calcium oxalate. There will be there will be leukocytosis. There will be an increase in the WBC count. Uh, in case of USG, if there is no risk of radiation exposure, and provide additional information about hydronephrosis. In case of obstructive stone, the USG, will tell you if there is hydronephrosis. If the stone is obstructive, there will be reflux of urine, and the entire kidney will get damaged. Also, you can do X-ray KUB or CT KUB, which is done today majority of the times. So these are the different types of normal and abnormal crystals. So the abnormal crystals are bilirubin, cholesterol, cysteine, leucine, tyrosine, sulfa, acyclovir, indinavir. So you have to remember the pictographic representation of all these, since the amount of image-based questions are increasing. Uric acid, calcium oxalate, hippuric acid, calcium phosphate, triple phosphate, calcium carbonate, ammonium biurate are the crystals which are found normally even in normal patients. So you will be able to identify the pictographic representation. They'll give you a clinical scenario, they'll give you a picture, they'll give you a picture of cysteine stone, and they'll make you identify and cystinuria, or it will be one of the options. So you should be able to identify. Now coming to the treatment of kidney stones, one is ESWL, so extracorporeal shock wave lithotripsy, in which you you break down the stone into small parts, and the stone gets removed. The stone gets passed away through urine. Now there is something called as percutaneous nephrolithotomy, which I have explained earlier. Percutaneous means via the skin. Nephrolithotomy. Nephro means kidney. You make a tomy means you make a hole, or you through the skin you approach the kidney and remove the stone. Ureterolithotomy. Ureteromy is through the ureter. Pylolithotomy.